Welcome. This PowerPoint accompanies the recent recommendations from REMO regarding patient destination for suspected stroke. With the advances in stroke treatment and management now available to patients, our pre-hospital management must also evolve to keep up with these best practices. So with this in mind, REMO and the REMAC looked at stroke care and came up with the following recommendations to help facilitate disposition of patients with suspected strokes, and more importantly, those with large vessel occlusive strokes, or LVO, to the appropriate destination. The pre-hospital decision-making tool selected by REMO is the FAST-ED score. Along with the score, REMO created an algorithm using the score from the FAST-ED tool to guide patient disposition. This algorithm was developed by a REMAC committee comprised of physicians from Albany Medical Center, Ellis, St. Peter's, and Samaritan, who worked with Albany Medical Center Neurology, Albany Medical Neurosurgery, and the American Heart Association. They evaluated several pre-hospital screening tools that aim to screen patients for the risk of LVO, and after their review, they settled on the FAST-ED tool. This tool uses clinical exam findings as well as key parts of the HPI to calculate a score which correlates to a risk that the patient has an underlying LVO. Using the score, the app and the algorithm offer guidance on destination selection. The committee chose this tool for several reasons: its clinical performance, its ease of use, and the fact that it came with an easy-to-use smartphone app. Now looking at the existing New York State collaborative protocols, they give good recommendations regarding stroke care, but they only discuss transporting patients to a designated stroke center. With the development of endovascular procedures and new criteria for designation of comprehensive stroke centers, this offers additional transport options and forces us to more closely examine which patients may need a more specified destination. These REMO recommendations are intended to help providers decide which patients may need to go directly to a comprehensive stroke center, thereby potentially bypassing the nearest stroke center, and which may simply be taken to the nearest stroke center. An important note with these recommendations is that the FAST-ED score does not replace the Cincinnati Stroke Scale. A Cincinnati Stroke Scale must still be performed to screen for suspected stroke, and if you do suspect a stroke on a patient, then you perform the FAST-ED score to evaluate for the risk of LVO and determine the appropriate destination based on their risk. REMO decided to create this algorithm and these recommendations in order to take into account local resources and capabilities. Now, some may be asking, what's the difference between a primary stroke center and a comprehensive stroke center? While all stroke centers, meaning both primary and comprehensive stroke centers, have the ability to perform advanced brain imaging, rapid neurologic assessments, and to give TPA, a comprehensive stroke center has the added ability to perform endovascular clot retrieval.
So why are we so focused on large vessel occlusive strokes, or LVOs? Strokes that involve blood clots in the largest of the blood vessels in the brain cause some of the more devastating outcomes. The large blood vessels in our brain give rise to smaller branches which then go on to supply large areas of the brain. So a blood clot upstream in a large vessel can affect a large area of brain downstream from the clot. The most effective treatment for these large vessel occlusive strokes is endovascular clot retrieval, which can only be done at a comprehensive stroke center. However, it's not always easy to determine who has one of these large vessel occlusive strokes without the aid of advanced brain imaging, so we rely on screening tools to help us. The goal of this recommendation is that every stroke patient gets the best care while doing so in a manner that can be measured and reported. Patients who are TPA candidates should be treated in a timely fashion, but it's important to remember that not every stroke needs to go to a comprehensive stroke center. The majority of strokes are not LVOs, and primary stroke centers are very well suited to caring for all stroke patients. If we were to suddenly begin transporting all strokes to a comprehensive stroke center, that facility would soon be overwhelmed and unable to provide the specialized care to those who would actually benefit from it. The FAST-ED score is important because it helps us identify who may potentially benefit from treatment at a comprehensive stroke center and allows us to triage patients to the appropriate destination. Now let's take a look at the app itself. You can download the app from the App Store or Google Play, and once it's installed on your phone, you can use the anonymous login to begin. To begin, you'll start by pressing the Start button. Once you start, the app will ask you questions about the patient's history and clinical exam findings. Simply follow the instructions and choose the appropriate response based on the patient's response or clinical exam findings. Once you complete the questions, the app will give you a score based on the responses and a probability of whether this patient may be having a large vessel occlusive stroke. At the bottom, there's a link to a map which will show the nearest stroke centers. You'll also use this score when referring to the REMO algorithm for patient disposition. So here's the algorithm REMO created to help guide destination choice for patients with suspected large vessel occlusive strokes. You'll note that the first step is determining what the FAST-ED score is. If the score is less than 4, meaning 3 or less, then the patient automatically goes to the nearest stroke center, and that still may be a primary or comprehensive stroke center. To enter into the pathway for determination of whether or not the patient needs to be transported directly to a comprehensive stroke center by bypassing a primary stroke center, the patient must have a score of 4 or greater. So let's now look at the algorithm for the patients who have a score greater than 3, meaning 4 or more. So at this point, you've performed a Cincinnati stroke scale and the patients come up as a positive for suspected stroke. You've then performed the FAST-ED score and you've obtained a score of 4 or greater. You then need to decide what destination is appropriate for the patient. The first branch point is whether additional transport time from the nearest stroke center to a comprehensive stroke center adds more than 30 minutes to travel time. So if it does not add more than 30 minutes and the patient has a FAST-ED score greater than 4, then that patient should preferentially go to a comprehensive stroke center and bypass any nearby primary stroke centers. However, if the transport time adds more than 30 minutes beyond the nearest primary stroke center to get to the comprehensive stroke center, then you enter down into the next branch point. Is this a wake-up stroke, or has it been more than 3.5 hours since onset with a presumed onset less than 24 hours? If your patient has a FAST-ED score greater than 3 and the travel time is more than 30 minutes to the comprehensive stroke center from the primary stroke center, but this is a wake-up stroke or their symptoms have been present more than 3.5 hours, then these patients should go to a comprehensive stroke center because they are no longer TPA candidates. However, if you have a FAST-ED score greater than 3 and the travel time is beyond 30 minutes, but they are not a wake-up stroke and their symptoms have been less than 3.5 hours, then they should go to a primary stroke center because these patients are TPA candidates. Once at the primary stroke center, they can get their TPA and be assessed for appropriateness for transfer to the comprehensive stroke center. So to review, a patient with a positive Cincinnati stroke scale must score greater than 3, meaning 4 or more on the FAST-ED score in order to enter into the algorithm for patient destination and bypassing primary stroke centers in order to get to a comprehensive stroke center. Those patients with a score of 3 or less are treated in the same manner as they were previously under the New York State Collaborative Protocols and will be transported to the nearest stroke center, which may be a primary stroke center or possibly a comprehensive stroke center. In patients with a FAST-ED score greater than 3, meaning 4 or more, we need to assess 2 other factors when determining our disposition. How much extra time is added by bypassing a primary stroke center to get to a comprehensive stroke center, and how long the patient's symptoms have been present. So remember, our goal is better patient outcomes. Familiarize yourself with the FAST-ED app and the REMO algorithm, and do your best to provide the best care for your patients. Consult your medical director or REMO if you have any questions. And lastly, these recommendations were made with ground transport in mind. If you are considering incorporating rotor transport into your disposition considerations, consult your medical director to determine how this can best be accomplished.